Okay, we are officially up and running. So I have several things we want to cover today because we're starting Unit 5. Before we go there, I want to hit on a couple common themes related to the exam. There were 2 questions on there that focused on delegation and things that can be delegated to the AP, to the LPN. So that's something I want to go back and kind of revisit a little bit just based on the entire concept of delegation, because that's something that you will continue to deal with moving forward. It's part of management of care, and that's a big chunk of your NCLEX. 16 to 22% of your NCLEX questions relate to management of care, and delegation is one of the topics underneath management of care. So I just wanted to kind of touch base on a couple things. When we think about scope of practice, we're generally looking at RN, LPN, and assisted personnel. That's what NCLEX likes to call them. That's your CNA, your patient care tech. They're called all sorts of different things depending on what facility you're working in. So when we think about the RN scope of practice, there's some buzzwords that you want to know. These are things you can brain dump on your scratch paper, but things that you want to keep in mind. If it involves assessment or evaluation, administration of an IV push medication, that is always going to be RN scope of practice. Now, here's the thing. You have to keep in mind, sometimes it doesn't always use the word assessment or assess, but if it is an assessment, then that's going to be your RN scope of practice. LPNs, based on the general definition across the country, NCLEX says LPNs don't assess, they monitor. Now, the reality is in real life, when your LPNs are taking care of your patients, they're performing the same assessment techniques that you are. They are assessing their patients. This is really semantics. But when it comes to testing and NCLEX, if the term monitor is there, because monitor refers to taking care of a patient who's stable, who has expected outcomes, and the LPN is monitoring that patient's condition, trending what's going on, and working underneath the RN. So if they're using the term monitor, that's a big clue in that this is an LPN scope of practice. If it is something that is very task-oriented, vital signs, intake and output, ADLs, things like that. Ostomy care on a patient with an existing ostomy, emptying the ostomy bag, that sort of thing. That would be appropriate for the AP. Now, I do want to put a little caveat on that, because when we're talking about delegating to the AP, we should be focusing on delegating tasks in a stable patient. So if you think back to Unit 2, urinary, where we talked about intake and output related to a continuous bladder irrigation. And we said that, yes, they could empty out the Foley bag and they could chart that. But when it came to actually calculating the true output, that's not in the scope of practice of an AP, okay? Other things that APs can do, yes, they can do blood glucose monitoring, okay? Now, that's a nationwide thing. Keep in mind, some facilities might limit that. Some facilities might not have their APs do that. However, when you look at the nationwide standards, it is in the AP scope of practice. I don't remember what the page is right off the top of my head, but in your ATI fundamentals book, there's a chapter on delegation. And I believe there's an actual chart in there that talks about things that can be delegated to an AP and things that can be delegated to an LPN. Those are things you definitely want to take a look at, okay? So kind of flag that in your ATI book to take a look at that moving forward. Another concept that I wanted to reinforce is when you have an NCLEX question that talks about an overall outcome. So when you're looking at how to best overall evaluate a patient, you're looking at something that's going to give you a global picture of how well things are going. And let's just use a diabetic patient as an example for this. There are lots of things that diabetics need to do as part of their treatment regimen. taking their medication, you know, following an appropriate diet, weight loss, particularly for your type 2 diabetics. So those are all things they have to do. But if you think about how you're going to best evaluate how they're managing their diabetes, you're looking at something that's very clear cut and objective. And your best way to do that is going to be their A1C level, looking at how well their management of their glucose has been over the last 3 to 4 months. Okay. So when you're looking at something overall, that's going to give you your best indication of how their disease is controlled. Okay. The other things are important, and those are things that I'm going to do, but simply losing weight isn't going to tell me, are they controlled or are they not? You know, is the treatment regimen working or is it not? So we're looking at an overall outcome. And the last thing I wanted to really talk about was priorities. And I think overall as a group, you guys are getting much better with determining what is the priority assessment or the priority action teaching point. There was one that was pretty tricky for you guys because there were 2 really, really close answers, and it related to diabetic foot care and what would be the priority point that the nurse would teach the patient. And most of you were able to narrow it down to, you know, what I would call the top 2. And one of them involved, you know, inspecting the feet daily for any cracks or cuts. And the other one talked about absolutely avoiding use of any type of heating pads or hot water bottles on the feet. So they're both really important. So when you think about those from an NCLEX perspective, okay, one of those things, if they do, is absolutely 100% going to cause harm. And that's going to be the one with the heating pad and the hot water bottle. Not that the other one isn't important. I definitely want to teach that. But if I could only teach one of those, I want to teach them something that is absolutely going to, if they do it, it's going to injure them. It's going to cause a problem. So that's why that is your priority point for that one. So I wanted to hit those 3 things in particular because those are common themes. As we move into Unit 5, that priority setting, that overall outcome and delegation are things that you're going to continue to see. So that's why I wanted to cover those. Speaking of Unit 5, so things are a little bit different with Unit 5, as you probably saw from the announcement. Unit 4 was kind of a half and half. We had half on campus and half with this wonky new online thing. Okay, now we're talking completely online. So now is where the rubber meets the road, and we got to pick this up because you have to engage with this content every single day. Okay, every single day. Those of you who are on Med-Surg alternate clinical right now, the cases that you have this week and all the students, the cases that you have next week relate directly to Unit 5. And I did that specifically because I wanted to be able to support you not only with learning this content, but also with applying the content. So here's the other thing. This unit focuses on respiratory concepts and cardiovascular concepts. You all had a unit in foundations, oxygenation and perfusion, and that really laid the groundwork for this unit. So it is not a bad idea to reopen your fundies book a little bit and look over that oxygenation and perfusion chapter. If you were using tailored 9th edition from last semester with Mrs. Brenchley, it's chapter 39. There is a lot of good stuff in there, and it really lays the foundation for what we're doing this unit, this semester, because now we're taking those concepts and now we're looking at specific disease processes. Now, that being said, this first day today, the first part of it, respiratory assessment, the treatment, the diagnostics, that is stuff that's very general, and it's going to apply to pretty much every respiratory disorder that we talk about, and every respiratory disorder you're going to talk about in Med-Surg 2, Med-Surg 3, and you're going to see in practice, okay? So what's nice about respiratory oxygenation and perfusion, these concepts are going to cross a lot of different things. So if you don't necessarily think about it as these are the interventions for asthma and these are the interventions for COPD and this is for pneumonia, but rather look at it across the board as these are interventions that are appropriate for respiratory problems, oxygenation problems, you're going to do much better. Because the reality is, whether I'm doing incentive spirometry for a post-op patient to prevent atelectasis or for a pneumonia patient, it's still incentive spirometry. It still works the same way. It still has the same underlying rationale. Why are we doing it? How do you do it? Okay, so definitely, if this was a weaker chapter for you in foundations, you want to go back and look at that stuff. The Taylor book, I'm fairly certain it has key points at the very end. There are also some practice questions at the very end, but it's really important that you have that foundational knowledge because we're building upon that. So that being said, we're going to kind of just do a brief review, talking very quickly about respiratory assessment. And you guys have been doing this all semester in clinical, a focused respiratory assessment. So when you think about observing your patients, so when they look, what they look like, when you look at them, you know, how is their breathing pattern? How is their breathing effort, both at rest and with exertion? Okay, what's that respiratory rate, the rhythm, the depth? Are they coughing? Make sure you ask them if they've been coughing too, because the 5 minutes that you go in to do your assessment, they might not cough, but the minute you leave the room, they might start hacking. So make sure you're asking about that. And when you're documenting, instead of documenting as no cough, if you have actively asked them, have you been coughing? Do you have a cough? And they say no, use the term denies cough. Okay, same thing with pain, not no pain, denies pain. Because if you actively ask them and they said no, you want to make sure you're conveying that in your physical assessment documentation. Other things that go along with the focused respiratory assessment, certainly oxygen saturation, their use of oxygen, how much, what is the delivery device, certainly lung sounds. One of the activities in the online class worksheet takes you back into Hinkle, kind of reviewing those lung sounds. When you get the opportunity to go back to clinical at some point, or even at home, if you have people at home, make sure you're using your stethoscope and listening to patients' lungs or people's lungs. Even if they're not sick with COVID-19, if they're, you know, have stuffiness or the flu or something like that, make sure you're listening to lungs. Get into the habit of fine-tuning that technique, listening to what it should sound like, normal, expected sounds, and then your abnormals. We typically have 3 adventitious or abnormal sounds that we kind of focus on. We have crackles, and if you're talking to a seasoned nurse, he or she might refer to them as rails. So if you hear in report somebody says they have rails in the bases, just substitute rails for crackles. Wheezes, which are fairly easy to identify. That's probably the easiest one to identify. And then you have your rhonchi, which are kind of like your lower pitched wheezes, a moaning type sound. That usually indicates some secretions actually in the airway, sticky secretions. So you want to be familiar with those. And when you're charting, you really need to make sure that you document the anatomical location. So if they have crackles, okay, but where are they? Where did you hear them? Did you hear them anteriorly, posteriorly, both? Did you hear them on the right, the left? Are they bilateral? Are they at the bases? Are they the apices? Are they halfway up? You just want to be very specific, because the reality is when the next nurse comes on, yes, you're going to give them verbal report. You're going to give them that SBAR report. But if they go to assess their patient later on and the patient has crackles, okay, crackles is an abnormal assessment finding. Is it expected for this patient? Well, depends. If they've been admitted with heart failure, if they've been admitted with pneumonia, I'm kind of expecting crackles. But then my next question is going to be, are they the same? Are they getting better? Are they getting worse? And your documentation is really important in helping the nurse determine that. Okay. Other things with respiratory assessment, you also want to look at their overall color. Just how are they doing in relation to their breathing, that oxygenation. Because when you look back at your anatomy and physiology, you have two pieces here. You have ventilation, which is the act of actually breathing the oxygen in and exhaling the CO2. And then you have the diffusion part, that gas exchange part down at the alveolar capillary membrane, okay? And then you have the perfusion part, which is the cardiac piece, but they all work together. So it's really important to kind of think about these disease processes. Is it a ventilation problem? Is it a diffusion problem? Is it a combination? Okay. Is it a perfusion problem, like your pulmonary embolism? So just kind of thinking through that anatomy and physiology. From a diagnostic test standpoint, you should all be familiar with chest x-rays. Probably the typical thing we see done on a lot of different patients. You'll often see a chest x-ray 2 view. So they'll do an anterior and posterior. So they'll take the picture looking, from front to back. But then they'll also have the patient turn to the side and they'll take a lateral view. So when you look at those orders in the charts and they say chest x-ray PA and lateral, posterior, anterior, lateral, that's what that's referring to, the two different views. ABGs, arterial blood gases, that goes back to foundation. So if it's been a while and you're kind of like, okay, I sort of know what an ABG is, you need to go back and review that. Part of your activities for today in the class PowerPoint and the associated worksheet is interpreting ABGs. There will be ABGs in this unit. There will be ABGs on the exam. So being able to interpret them is very important. So you want to work through that PowerPoint. There's some examples on there. Always look at the pH first. Is it acidic or is it alkalytic? If it's normal, what side is it falling to? Which side is it trending to? Then you're looking at the PCO2. Again, if it's high, it's acidic. If it's low, it's alkalytic. You're looking at the bicarb. If it's high, it's alkalytic. If it's low, it's acidic. So which one is going in the same direction as the pH? That's how you know, is this a respiratory or a metabolic problem, okay? And then if the one that's opposite of that is going in the opposite direction, that is going to tell you that there's some level of compensation going on there. In reference to the compensation, and this is the respiratory unit, so we're focusing mostly on respiratory here, but you want to understand about compensation because your body is very much like Goldilocks and the Three Bears. It doesn't like to be acidic. It doesn't like to be alkalytic. It wants to be just right in that pH. So it's going to try to compensate and adapt to get that pH back within that normal range, that's 7.35 to 7.45. And it's important to kind of understand that compensation piece. Other big diagnostic tests, certainly things that we've talked about this semester, CT scans, particularly if they're using CT scans with IV contrast. I feel like I'm beating a dead horse here. You guys know about check-in for allergies, about looking at BUN, creatinine, GFR, holding metformin at least 48 hours post IV contrast studies. That's kind of a given. You guys know about MRIs. They can't have any metal on their body. They can't have any patches on, no pacemaker, defibrillator, things like that. Something that's probably new to you with this unit as opposed to foundations would be the PFTs, or the pulmonary function tests. That's something we look at much more in relation to COPD and diagnosing and tracking COPD. But basically you're just looking at, what capacity of their lung function do they still have when they're looking at forced exhalation, their inspiratory volume. So that's something to kind of look at. I don't necessarily care that you know all the numbers related to PFTs. I want you to know what they're used for. That typically the patients that we see in the hospital with COPD, they're there for an exacerbation. That is not the time to do pulmonary function tests on them. You want to get them over the hump of that exacerbation, and then they'll test them as an outpatient, depending on when their previous PFTs are. They're very helpful in tracking the progression of COPD. So that's typically where you'll see those used. I want to move on to treatment modalities, okay? Specifically starting with oxygen therapy. There's a good resource up there, a Freebie Friday, that talks about the different oxygenation delivery devices. It's important to know what device you should use when, how many liters of oxygen you should put on with each delivery device, what's appropriate, what's not. Your book and your ATI go a little bit into mechanical ventilation. We're not going to touch that in this unit. You're going to hit that in Med-Surg 2, Med-Surg 3. We're kind of doing the stuff, you know, before we get to the point that they're on the vent. Now, that being said, we do talk a little bit about CPAP, especially in relation to obstructive sleep apnea, as well as BiPAP. And those are very helpful for patients that are struggling to breathe. Because when you think about the process of ventilation and how when you inhale and you take that oxygen in, it's expanding out the alveoli. When you're exhaling, those alveoli are essentially collapsing. And then you take a breath in and they reopen, they collapse, and it just keeps happening over and over again as you breathe. In a very basic way, the CPAP and the BiPAP really help those alveoli not completely close, so it's easier to take that next breath. So you will often see CPAP used with sleep apnea, but BiPAP used kind of as a last resort before we get to the point where we now need to intubate the patient. So oxygen therapy is pretty important. Don't forget about the basics. You know, we're always talking about, you know, regulating the oxygen and checking the O2 sat, but don't forget your basic nursing care. Skin breakdown with oxygen delivery devices. If that mask is too tight over the face, that nasal cannula pushing into the skin, behind the ears, underneath the neck, really watching for those sort of things. Also keep in mind, oxygen is very drying, so it's going to dry out the mucous membranes of the nose and mouth. That will put your patient at higher risk for bleeding. They could have nosebleeds. So you really want to take care of that. Again, you always want to use water-based lubricants. Sometimes we'll use saline nasal spray for the nose. You may even use like a KY type lubricant around the prongs of the nasal cannula to make that a little bit more comfortable in the nose. You never want to use any type of petroleum-based lubricant with oxygen, just because of potential fire hazard. Positioning. We've talked about this before. It's a foundational concept. If your patient's having difficulty breathing, for the most part, we want to be able to sit them up. It allows for greater lung expansion. Usually they can catch their breath a little bit better. Coughing and deep breathing. Okay, why is that important? Well, it all goes back to the ABCs: airway, breathing, circulation. Okay, when you're turning and repositioning, you are mobilizing secretions. If you think back to your anatomy and physiology, you have little cilia in your respiratory tract, and they're catching particles, and they're trying to put them back up and get them back up your respiratory tract till they get to the back of the throat, and it makes you cough, and then you either hawk up the loogie or, you know, you swallow it. Kind of gross, but whatever, it's still out of the airway. The airway is clear. Repositioning, turning, that's really important for mobilizing those secretions. If you have someone who's sitting in the same position or lying in the same position for a long period of time, you have pooling of those secretions. So turning them, repositioning them helps mobilize those secretions. And then the deep breathing and the coughing helps bring those secretions up so they can be expectorated. Okay, so really, really important. Coughing and deep breathing is most effective if done after a breathing treatment, particularly your bronchodilator, because now we're opening up that airway. We've kind of probably stimulated that cough reflex a little bit. We do some deep breathing, coughing, they're more likely to get that sputum up. Kind of along those lines, chest physiotherapy, and we have chest percussion. We also have vibration. This also is about loosening and mobilizing secretions. These are very helpful. Again, if the secretions are looser, it's easier to cough them up. And particularly in disease processes such as cystic fibrosis, where they have excessive amounts of secretions, that's going to be really important to try to loosen those secretions in order for them to be effective in coughing them up. Incentive spirometry. very helpful in opening up the alveoli. We use it preventatively for our post-op patients so they don't develop atelectasis, they don't develop pneumonia, but they can also be used for your regular respiratory patients as well. Now, something new, evidence-based practice, if you're giving your patient an incentive spirometer while they're there with a potential infection, we used to send those home with the patients because, hey, you know, let's use them, let's open up the lungs, that's a great thing. If they're there and they have an infection, they actually now recommend you do not send those home with the patient just because they've been breathing on them and hacking on them and they have bacteria and stuff on them. Post-op patient, probably okay, but I would tell them, I mean, don't hang on to it for years. It's not something you want to keep and put on your bookshelf, you know, as a little trophy of your surgery, just because of the risk of, you know, reinfection and that sort of thing. Suctioning is another important intervention. As a skill, you will learn about suctioning in MedSurg 2, and you'll actually do that as a skill in the lab and on clinical. But just basic understanding of suctioning, important to keep the airway open. It is a sterile procedure because we don't want to certainly introduce any pathogens or, you know, bacteria down there. So it is a sterile procedure. You also need to kind of keep in mind that we apply the suction on the way out. So when we're pulling out the suction catheter. Other key principles with that, you always want to hyperventilate your patient, hyperoxygenate your patient before you do the suctioning. This can either be with an ambu bag, it can be giving them some really concentrated oxygen for about a minute or so before we suction them. But you always want to hyperventilate that patient prior because their sat is going to drop during the actual suctioning procedure. The other big thing that was in some of the PowerPoints today related to the medications. And you'll look at that as part of the online worksheet. It has you comparing your pre-class prep to some of the slides that are in the PowerPoint that has the key priority, need to know information about those medications, but just having an understanding of how these work. With your bronchodilators, that, you know, they do exactly what they sound like. They open up the airways, they dilate the bronchi, the bronchioles. If you have a more open airway, it's easier for air to flow through there. Couple points I like to make about bronchodilators. You need to understand is what the specific one that you're giving to the patient, is it short acting or is it a long acting one? Long-acting bronchodilators, your anticholinergics, those are used for long-term management or maintenance therapy of respiratory disorders. So you see these used a lot for patients with chronic disorders, asthma, COPD, okay, CF, cystic fibrosis, because we're looking at gaining long-term control. Now, your short-acting bronchodilators, the most common one you're going to run into is going to be your albuterol. That is used to treat acute symptoms, get that airway open. A lot of times patients are given them together. They might be on a duo neb, which has albuterol and ibupropium in it. So you have a short acting and a long acting in there. And then if they need a breathing treatment between their scheduled duo nebs every 6 hours, they'll give albuterol by itself, that short acting bronchodilator. So important to kind of know about them, how they work. Albuterol in particular, major side effect is it will cause tachycardia. Now, in most patients, that's not generally a problem, but if your patient's resting heart rate is already over 100, and now we're putting albuterol on board, we're going to increase their heart rate. Now, why is that a problem? Well, this kind of ties into class 3 for unit 5, because if you think about when your heart is actively beating, it's pushing out the blood to the body or, you know, or to the lungs, depending on what side you're looking at. But if you think about what's happening when the heart is relaxed, when it's not contracting, those ventricles are filling, okay? So if the heart is beating so fast that the ventricles don't have adequate time to fill, you're gonna have decreased cardiac output, and your patient can only tolerate that for so long. So that's why knowing that the albuterol causes tachycardia, as the nurse or as the respiratory therapist, That's one of the things they look at both before and after giving an albuterol treatment. They typically go in, they're going to look at their respiratory rate, they'll look at their heart rate, they'll look at their O2 sat, they'll listen to their lungs. We'll give the treatment. They're going to check those things again afterwards. It's also important after any type of inhaled respiratory med that your patient rinse their mouth out for a couple reasons. One, some of these things can leave a nasty taste. Two, the steroids, which we'll talk about in a minute, can actually alter the normal flora in your oral cavity. And if they're not rinsing their mouth out, they can develop what we call thrush, or basically a yeast growth in the oral cavity. So rinsing their mouth out after use is really important. And the last thing I really want to mention with the bronchodilators is understanding that they can come in different forms. I've kind of been talking about the nebulizers. So those are a liquid form. You know, we put them in a little device, we hook it up to either preferably air, but I have seen them linked up to oxygen tanks as well, to basically aerosolize the medication that the patient is then breathing in. So they can come in that form. They can also come in the form of meter-dosed inhalers, okay? They can also come in the form of dry powder inhalers, or DPIs. Now, your DPIs are generally your long-acting stuff. If you're looking at short-acting, you're typically going to see that in an MDI or a nebulizer. If you are giving multiple respiratory medications, like let's say, for example, your patient has a Duoneb ordered, and they're also going to be getting Advair, okay, which has fluticasone and salmeterol in it. The Advair is a dry powder inhaler. Actually, the new version of Advair is now a meter dose inhaler, so it's a little bit different, but you always want to give your short-acting bronchodilator first, because the whole idea is to help get that in there, open up those airways. The other medication is going to be able to get down much farther. In relation to the corticosteroids, and I mentioned Advair, that's one of them. There's other combination meds that are out there, typically in MDI form or a dry powder form. There are some that are available in a nebulizer form. Pulmicort is one. But again, they're steroids. They're all about reducing inflammation in the respiratory tract, in the respiratory cavity. So we mentioned about rinsing the mouth afterwards, giving the bronchodilators first. Understand that long-term use of corticosteroids, remember we hit this back in Unit 3, will predispose this patient for the development of osteoporosis. So just some things to kind of keep in mind. The other thing that I want to kind of hit on with the steroids is that I've been talking about the inhaled ones. If your patient is actively having an exacerbation, that's when they're going to use either a PO form of the steroid, typically prednisone, or possibly IV. Usually that's methylprednisolone or solumedrol. Okay. Other medications, antihistamines, those are typically used for your upper respiratory infection, your congestion, your sneezing, your hay fever type symptoms. With the antihistamines, you'll see in the PowerPoint, big issue with your first generation ones is they can cause sedation. That's your Benadryl. Oh, very good question. I have a question up here. If they are tachy and they're having trouble breathing, what would the intervention be since albuterol isn't recommended? Okay, well, albuterol may not be recommended, but again, if you're looking at they can't breathe versus circulation, we have to open up that airway. What they will typically do if a patient is having issues with their heart rate being up that high, they will often put them on a beta blocker, or in some facilities, there is a cousin to albuterol. It's called levalbuterol, also known as Xopenex. That particular form does not have the side effect of tachycardia. So the next logical question would be, well, why don't we use Xopenex for everybody? And what makes the world go round? It's green, it's money. The reality is Xopenex is extremely expensive in comparison to, relatively cheap albuterol. And if they can manage the heart rate using other medications, we're going to do that. But the bottom line is, if your patient doesn't have an open airway, if they cannot breathe, if they cannot oxygenate, cardiac output's not going to mean anything, because it's just going to keep dropping because they're going to be hypoxic. Okay, getting back to the meds, expectorants, medications that will help usually mucolytics and expectorants kind of go together. These are things that are going to thin out the secretions, and the expectorants will actually stimulate and trigger a cough because we want to hack that stuff up. Guaifenesin is probably the one that's most widely known. What tends to fascinate students is guaifenesin is the same thing as Robitussin. It's also the same thing that's Mucinex. And you've all seen Mucinex advertised on TV. Whoever the marketing person for that developed the little mucus guys that talk to each other. I mean, that's just classic, that's gold. And that's why, people just absolutely love Mucinex. It's the same thing as Robitussin. It really is. Things to keep in mind, especially with the expectorants, and really for all respiratory patients, we want to promote hydration, because the better hydrated your patient is, the thinner their secretions will be, and it's easier to cough up thin secretions than it is thick secretions. So hydration is really important for these patients as well. Yes, expectorant. Which med triggers a cough? That would be expectorants. Those are things we want to get that stuff up. Mama always said, get that junk up, hack it up, okay? Now, on the flip side, we have a class of medications called antitussives, and these are used to actually suppress a cough. So it's really important to kind of think about which one is appropriate to use, or sometimes your patients will have both prescribed, and when is it appropriate to use each one? Obviously, if they have a moist, productive cough, we want that stuff out. We want it out. So an expectorant is going to be helpful there. But if they are coughing and coughing and coughing all day long and they're not getting any rest whatsoever, that's going to be detrimental to them as well. So we do need to provide for some periods of rest. And that's when they might use an antitussive, such as Tessalon pearls, something like that. Your Delsum, that's very helpful in kind of quieting that cough. Also, if it's a dry cough, like there's just nothing there, it's not coming out, but it's persistent, they will often use antitussives for that as well. Again, sometimes they'll use them both in a patient, and you just need to kind of think about, when would it be appropriate to use an expectorant, and what times throughout the day would it be appropriate for that antitussive. And a lot of times the antitussives will be prescribed PRN. So this is where your nursing assessment skills and your nursing judgment is going to come into play. But again, it's all about maintaining that airway, but we also need to balance their activity and rest. And even though we don't think about persistent coughing as activity, it is. They're sitting up, they're working to breathe, they're hacking. That really does take the wind out of them. Certainly antibiotics for infections is very important as well. It's common knowledge an antibiotic is not going to treat a viral infection. So when we're talking about upper respiratory infections, they might be a little bit more cautious against prescribing antibiotics just because a lot of them are viral. However, if you have somebody who's coming into the hospital with respiratory difficulty, particularly if they have underlying asthma, COPD, CF, anything like that, chronic bronchitis, they will likely start them on an antibiotic. And here is the reasoning. Yes, we know it could potentially be viral. It may not be. And if we wait to determine whether or not it's viral, that patient may already be dead. Ideally, we don't necessarily want to use antibiotics inappropriately, but at that point, if they are having that much difficulty breathing and the underlying cause is actually a bacterial infection, if we delay treatment, we're putting them at risk for death. So when you look at the benefit versus the risk for that particular population of patients, we're going to give that antibiotic. Okay, and typically if it's to the point where this patient's going to be hospitalized, they're going to require IV antibiotics. Okay, that we're kind of past the whole PO thing at this point. So those were kind of the key points I wanted to cover. I did see a question that came up. Are we going to go through the class PowerPoint? I'm actually not going to go through the class PowerPoint slide by slide. The purpose for that to be up there with the associated online class worksheet, is to get you to kind of go through things. I will, with our next Zoom session on Friday, I can revisit the worksheet and clarify any concepts from the class PowerPoint at that time. But the whole idea is to get you guys in there to be looking at that. Great question. When is the online worksheet due? I actually didn't put a due date on it. I didn't even put it as a required thing. It's there as a tool for you to make sure you're getting what you need to get out of that class PowerPoint. So I don't necessarily have it where it's due. I don't have it. It doesn't count towards, you know, your grade or anything, or to your quiz grade. It is strongly encouraged. I will tell you to really keep yourself on track, because as I was looking at your journals last week, and I did read every student's clinical journal. If you submitted a clinical journal with your paperwork last week, I did read it. And one of the common themes that came up was students were concerned about staying on track because they're out of their routine. They're out of their, you know, where they would go to school, and I would study at the library and I would do this. So that's tough. That is absolutely tough. And this is where you're going to have to get yourself back into a routine. You're going to have to schedule your time, like, okay, well, this is my time I'm going to be dedicating to 188. This is my time I'm dedicating to farm, for those of you that are taking farm, or to topics. So that's going to be really important. And that's actually why I chose to do the conditional release, that you couldn't see today's class PowerPoint in the worksheet until you uploaded your prep. You know, that's why I have that there, to kind of keep you on target. What I would tell you as a target for the online worksheets, I would target to have those done by the next class, by the next time your prep is due for the next class. But it's going to be really important to stay consistent with engaging in this material. Now, the flip side of that is a lot of you have taken care of respiratory patients in clinical, or have dealt with patients post-operatively developing respiratory complications. So we see a lot of these patients. Hopefully you've taken care of some of these patients, either in Foundations, MedSurg 1, so you can kind of relate that to what you're doing in clinical. You can also relate that to, you know, the alternate clinical experience cases. Let me see what my questions are here regarding the test. Do you only use the generic name of the drug for questions on the test? Well, truthfully, I haven't even written the test yet. That's kind of on my to-do list for this week. Yeah, well, with NCLEX going to pretty much using just generic names, that is my goal, to just use generic names on there. I do kind of put both usually in the PowerPoint, mainly because I want you to kind of recognize some of them out at clinical. But when NCLEX tests you, it's going to be based on the generic name. So I want to try to mimic that as much as possible, because that's what I'm preparing you for, you know, to get you ready to take that test. If we complete it and submit it, will we get bonus points? I don't think so on that one. The bonus is you're going to do better on the exam because you'll know the concepts better. Are we going to go over the class quiz questions? Oh yeah, we could do that. I totally did not have that on my list of things. Hold on, let me pull up my quiz here. Let me find 20 gazillion folders that I have open here. Okay. Just give me 1 minute here. I'm trying to open this up. Okay, so on the quiz, okay, so today's quiz focused on a little bit on medications. So medications that makes the cough more productive. That was guaifenesin. That is also known as Robitussin or Mucinex, and it is an expectorant. Okay, so I can't tell you what letter that was because I'm not quite sure how Plato did that. A bicarb result of 39 milliequivalents per liter on an ABG is considered alkaline. Okay, remember your bicarb is your metabolic indicator. Normal is 22 to 26 milliequivalents per liter. So when it's elevated like that, it would be alkaline. Okay, next question. Sedation, dry mouth, and constipation are all common side effects of this medication. This is diphenhydramine or Benadryl. So that is your first generation antihistamines. Number 4 was a medication that acts on the CNS to quiet coughing, and that was your dextromethorphan, also known as Delsum. Okay, that is an antitussive. Okay, other questions on here. A patient with influenza will be placed under airborne precautions. That is false. Those patients are put in droplet precautions. Remember, the difference is the type of mask that's being used. For droplets, you use a regular surgical mask. For airborne, you're using an N95 respirator. Also, airborne precautions involves a negative pressure room. Next question, positive reaction on the MAN2 tuberculin skin test is based on erythema at the injection site. That is false. It's not based on the redness. It's based on the induration or the firmness around the injection site. So that's why when people are checking your PPD, they're not just looking at it, but they're actually taking their finger and feeling over top of it. We're feeling for the induration. An early sign of hypoxia is restlessness. Okay, hypotension and cyanosis are indicative of hypoxia, but those are late signs. Okay, the length of time for the you know what? I don't even know that I used all these questions. I don't know. I'm just going to go over them anyway. This is an old quiz. Hopefully I'm hitting everything. Length of time for the flu vaccine to provide protection is 1 to 2 weeks. Soft, low-pitched sounds heard over most of the lung field are going to be your vesicular sounds. That is a normal sound that you should be hearing over the alveoli. And most frequent symptom of lung cancer is coughing. Get back here. All righty. So I think that was everything. I'm hoping that was the questions I put on the quiz. It's labeled as class 1, so I'm hoping that. Let's see. Was that flu injection in any of the reading of the pre-class prep? I believe it was in part of the reading, and that was more just something that you want to know, because as nurses, we're doing health promotion. The flu shot is something that is recommended, and that is why they continue to recommend the flu shot even when it gets later in flu season, because there can still be some protection, but it generally takes a week or 2 for that. Let me take a look at other questions here. If you have questions, go ahead and type them into the box. Let's see here. The email sent out. Yeah, okay. So some of you probably already got an email that said Unit 4 exam topics to review. That is not an assignment. That is just an FYI to you. If you did not get yours yet, there's about 12 of you still on my list. As soon as I'm done with this, that's the next thing I'm finishing up. But if you haven't already gotten an email that talks about Unit 4 exam topics to review, you want to be watching for that. Okay, I don't have any additional questions on here. So kind of last call if anybody has anything else. How long is the flu vaccine good for? Yes, so what they generally do is they recommend flu vaccination annually. Because they will change the vaccine based on the strains that they anticipate will be circulating. When we talk about that, we live in the northern hemisphere, and you think about Australia being in the southern hemisphere. So our flu seasons are opposite, because when it's wintertime for us, it's summertime for them, and vice versa. So a lot of times our flu vaccine that we use here is going to be based off of the strains that were circulating during their flu season down in Australia. I kind of like to say the flu vaccine is like going to the casino, because sometimes it's a crapshoot. They are essentially basing the vaccine on the strains that they think will be circulating. Some years it's a good match, other years not so much. But they do change it up every year based upon what they think will be circulating. And that's why the recommendation is for an annual flu vaccine. Now, that being said, I'm going to get on my soapbox here for a minute. It is not the end-all, be-all thing to keep you healthy. It is a part of what you can do to help keep yourself healthy. So please, as a nurse, you do want to encourage the flu vaccine. However, don't let your patients fall down on your basic common sense everyday infection control purposes and techniques, like hand hygiene, washing your hands, not touching your face, staying away from sick people as much as possible. If you're sick, staying home. Okay, nurturing your immune system through good hydration and good nutrition and getting adequate sleep and rest. Those things are all very, very important. The vaccine is one thing that your patients can do to help keep themselves healthy, but they shouldn't be falling down on those other things. Okay, and understanding that it doesn't provide blanket protection by itself. Let's see. So the more you get the vaccine, the more types of flu you will become immune to over time. That's the theory. That's the idea. If you think about your basic immune function in your body, when you get exposed to something, you know, the common cold, your immune system essentially gets, you know, sensitized to it. It kind of creates memory cells. So the next time you're exposed to the exact same thing, your immune system should be cranking out antibodies and be able to fight it a lot easier. And that's the idea of, you know, patients generally don't get chicken pox again after you've had a case of the chicken pox. Unfortunately, with the chicken pox, because we now do vaccination for that, nobody is ever exposed really that ongoing exposure to natural chicken pox. So your immune system doesn't get practice. And now we've been seeing higher cases of shingles. And now that's why they've come out with that shingles vaccine. But the whole idea is when you get exposed to a particular pathogen, particularly a virus, is that your immune system develops a memory. And then when it's exposed to the same pathogen again, it comes out fighting. And you tend to deal with it a lot better. Either you don't get sick at all, or it's a very mild illness. So, any more questions at all? Okay. All right, well, I don't see any more of them. Do make sure you're staying up to date with your studying and review. A little bit every single day. Please try to do little chunks throughout the day. I encourage you, even though you're all social distance right now, I do encourage you to keep in touch with your peers. A lot of times talking through the information is so important to learning. So if you can get on your own Skype or your own Zoom, with a group of you, 3 or 4, your clinical group, I strongly encourage you to do that. Talk through the material, talk through patients that you've taken care of, talk through, you know, the alternate clinical experience patients, but really focusing on how do I take this information and apply it to patient care. Okay, so that's great. I know all about these oxygen delivery devices. How do I implement that into patient care? If I'm taking care of a patient who's getting 4 liters of oxygen nasal cannula, what do I need to do? What should I be assessing? What can I do to help prevent the drying of the mucous membranes? What if they're a mouth breather? But talking through that material, very, very important. Okay, I don't see any other questions, so I am gonna sign off. Enjoy the rest of your day. Don't procrastinate, start your alternate clinical stuff. Stay safe, stay healthy, stay social distance, but still connect with your peers, okay? All right, take care.